Yeah, good afternoon. Can you hear me? All right. All right. I think now it's okay. Okay, excellent. All right. So, welcome to session 8, right? And okay. All right. So today we'll be talking about the second part, right? This is the second session for arm. Now, in fact, this session is very easy. Actually, it is very easy. The reason behind it is that most of the complex part you have already covered, and you guys are pretty good in that, right? Because yesterday, what you answered that was really nice. So today you'll find it much easier, right? So in this section, our prime focus would be on one, that big boss muscle, that is the triceps, and the beautiful pair of that royal radial nerve and the accompanying profunda brachii artery, right? So these two actually, so one muscle and one pair, that would be in our prime focus. That's for today. All right. So here it is. Now, as we said, that's the triceps, right? So this is the long head of triceps, and that's the long head of triceps, and that's the lateral head of triceps, correct? Lateral head. Let me draw it properly, right? We see both of them separately. That would be much better. So let's say this one is the long head. Now, where exactly this long head is connected? You must have seen that as the long head goes from the top to bottom, right? Say this is where it goes for the infraglenoid tubercle, right? It is the infraglenoid tubercle of scapula. Here it is. That's the infraglenoid tubercle, right? And how about this lateral head? Right? This is lateral head triceps. This lateral head triceps, on the posterior aspect, there is a groove, right? There is that groove, and that groove is the radial groove. Today, radial groove will be coming again and again, right? With respect to almost every structure. So that radial groove will be giving, so upper part, so here it is like upper part of, say, this posterior surface of humerus, right? That's where it is connected. Upper part of posterior surface of humerus. It is covering quite a big area. So it is actually like a near this radial groove. So that's what it would be covered. And as we proceed further, now you know this. This is like a medial head, correct? That is the medial head of triceps. Now this medial head, this is below radial groove, right? So that's the best part. It is below radial groove. So now it becomes much easier to remember. Medial part is below radial groove, and over here lateral part is almost on the groove, and this long head, that is on the infraglenoid tubercle, right? So that's how actually the whole triceps is arranged. let's move further. Now, when it comes down, obviously all these heads, right? All these heads, they will combine together, and that's where it goes for triceps insertion, right? Triceps insertion. And like biceps, over here also, all of them, they will be in the form of, I just mark it over here like this. Yeah, this is better, right? This is superficial. This is superficial flattened tendon, right? And we give a name to that, and that is like aponeurosis, right? Aponeurosis. So though we can tell it like flattened tendon, but again, we can also call it aponeurosis, and it lands on this particular point, and that is what is called as the olecranon process, right? So next time when we'll be dealing with the forearm, it will become still more clear because we'll be touching even rest of the muscles. But because this is only the posterior part of the arm we are dealing with, so that's why things will be only restricted up to this point. Okay, now one very important point is that this medial head fibers, right? Those medial head fibers, they are actually spreading onto the capsule of joint. So whenever the fibers, they are going on the capsule of joint, right, they simply provide what's called as the strength. And one of the best example of this was those rotator cuff muscles, right, which we used to write like, by the way, you remember rotator cuff muscles, which are the muscles involved into rotator cuff, right? Four muscles. And we were writing it in a very special style so that we don't commit mistake. You remember that? Rotator, right? Though it is in the shoulder, but still I just felt like asking. So rotator cuff muscles, that musculotendinous ring which is providing strength and support, right? Yes. So it is, we write it like S, I, actually T and the S. So they were, yes, they were like supraspinatus, infraspinatus. Then this is exactly because it is small, so it is teres minor. But that's the point. That's what where you should not commit any mistake. And the subscapularis. Good. Okay. That's right. That's right. All right. So let's move further. Here it is, just another view of this medial head triceps, right? How those fibers they really go, and actually when we'll see that this is the area where there'll be the formation of capsule. So that's how these fibers of medial triceps, right, they will be supporting the capsule, and thus they give the strength. Okay. Now let's come down to radial now. That radial now, which will be covered in depth today. Actually, we'll see that what radial now will be doing in axilla. Then from axilla, it comes into the posterior compartment. Right? Before radial groove, what it will do? In radial groove, it will supply whom? Then it will take turn, it will come into the anterior side. Then it will be divided into branches. And those branches, they'll be going all the way into the foramen. So much so, they'll reach up to the hand. So actually, we'll watch the entire course of radial now, right? It is very important also. So it's not so that without any reason we were calling it a royal now, right? It is a royal now. Okay. So now I need not say that radial now is like from that continuation of that posterior cord. True? That's right. That's right. So over here, see, these are the two heads. right? This is the long head and that's the lateral head. There is, first thing first, that this radial nerve, it will be giving muscular branches to long head and lateral head separately, right? So it will give one branch to say long head, another branch will be given to lateral head, right? So that's the first concept. Okay, moving further. So this is the action. The main action of triceps is extension, right? Now here, as we'll be touching the clinical part also today, right? Because the structures are less, so that will be able to finish very fast. And as you have got clean concepts of that about the radial nerve, about the median nerve, and the ulnar nerve, so those guys will be completed within no time. So that's why I have put some of the clinical things. Now for clinical, one very interesting thing is that say that Orb's palsy, right, or that policeman tip or the waiter's tip or the porter's tip hand, why it happens, we'll actually analyze it fully, right? So we'll go from top to bottom, that is which muscle is involved, what it will do in case if it is not doing its function, so then what would happen, right? So remember one principle. Your hand is exactly straight simply because of not one muscle, but it is the joint effort of both the muscles on the both the sides. That is the flexor group and the extensor group. It is the joint effort of both of them. Both of them, they are pulling the hand towards each other, right? This is towards themselves and this is pulling over here. That's why the resultant factor is this. For any reason, if one of the component fails, obviously this is working normally, but the pull will go towards this side, right? So when we say there is a wrist drop, why there has to be wrist drop? Because it is like those extensors, they were pulling the wrist up, but now these extensors, they are not working. So these flexors who are working normally, they simply did it like this, right? So when the fingers, right, when the fingers, they are like this, right, hyper extended, so it is not so that something wrong is going to happen with the extensor compartment, but because now the function of flexor were to bend the fingers, they are not working. So it is the normal activity, but the relative overactivity of those extensors and the fingers are going into that position, right? So just remember this principle and all the clinical things will be completely easy. So over here, officially, triceps is a very powerful elbow extensor, right? It is a powerful elbow extensor. Now see, maybe yesterday it was looking like a very complex jungle, but now even if I zoom this thing, you will be knowing, I think, every component of it, right? No doubt about it, right? So over here, as we know that our today's focus is radial nerve, right? So that's the radial nerve. That's the radial nerve in axilla, right? In axilla. So from axilla, right, it goes posteriorly, right? So that's in axilla. And over here at this junction, it goes posteriorly. And then it goes on into the radial groove. And then it comes out over here from posterior to anterior. And at this junction, it would divide, right? So far, so good. Now this radial nerve, because of this very peculiar course, right? It is also called as, it is also known as musculospiral nerve, right? Well-deserved name, right? Musculospiral now, because it goes like that. So that these are the points which we watch for, that how it goes posteriorly and then it comes out anteriorly. Yes, we know this part, that it would be piercing which septum, no doubt about it. It has to be the lateral intermuscular septum, because none of the other septum would really come at this point, right? There is only one which is on the medial side, no doubt about it. It won't be touched at all. All right. Over here, this is the posterior view. As we are watching it from posterior, things are pretty clean, right? That's what exactly happens. And this is the area of now our interest. That's the area, right? That's the area, right? I just highlight it and then I'll remove it. Right? Okay. So this is the area, and that's radial groove. Correct? That's radial groove. So whenever there would be fracture of shaft of humerus, surely it would be involving even the radial nerve, right? This is just for now. Once again, we are in anterior view, right? Keep orienting yourself very properly. We are into anterior, as this is a huge one, right? Now, which artery it is? Yes, it is, right, axillary or brachial. I'm writing it like this because we have not drawn the muscle, so that's why we are just telling that yes, this point could be, right? Anyway, so this is the radial nerve in association with the brachial artery. So this artery, it is lying just right. This artery is always in front, right? Always in front. So our radial would say, in any case, you remain front, because I'm in any case will be going to the posterior compartment. So no issues, right? That's the radial nerve. And we just wanted to emphasize this point, that this artery is in front of the radial nerve. Radial nerve in any case is not objecting, right? It has to go posteriorly. So it will say, okay. But radial nerve will say to this brachial artery that just for my company, give me one branch. And this axillary or the brachial will say, okay, take the profunda brachii, right, with you, and then they will make the pair, right? So that's how the profunda brachii, also known as the deep radial artery, they will go together. So here it is, right? The entire zoomed version of this. Now, see, as we are watching, this is the radial nerve in groove, right? In groove. So actually it is very closely associated. So those muscles, etc., when they are connected, right, they will be on this surface, over here. Right? So thus this artery is very closely associated with the bone. So there is minimal space available. That's the reason that whenever the bone breaks, right, whenever the bone breaks, actually it damages this particular nerve also. And here it is, right? What we are watching, this is the posterior view, but in this posterior view, we are interested in this level, this level. It is at this level when it pierces that intermuscular septum, right? And that intermuscular septum is lateral one. So it pierces lateral intermuscular septum and then it becomes anterior, right? It becomes anterior. Now, what exactly is the distance, right? If you really want to be a bit accurate, so how will you define that it at which level it really pierces the lateral intermuscular septum? Its importance will be when you'll be going into surgery, right? When you'll be going for it. So it's like deltoid tuberosity is very easy to figure it out, right? So deltoid tuberosity. So that deltoid tuberosity, from that deltoid tuberosity, it is about 5 centimeters or 2 inches, right? 5 centimeters or 2 inches. 1 inch is 2.5 centimeters, right? So 5 centimeter or 2 inches, that's the distance where it will really pierce the lateral intermuscular septum and will become anterior, right? So that's the extra piece of information which we learned today. This is just what you have to remember. Otherwise, up till this point, most of the things are known to you. Triceps, right? Now you know that triceps, yes, the medial head that was below. So this would be the portion of medial head, right? Lateral head that was above, and the long head, that's why it was called long, because it was traveling all the way to, you're right, infraglenoid tubercle. Excellent. Okay. So, well, you know these parts now, right? So that's the radial nerve. Now you guys are experts, so that's why I can ask that which is, right? It is actually, right, showing just a small piece of nerve, but I know that you'll be able to answer this. One, what is one? I know you'll be able to answer this, what is two? And I'm very sure that you'll be able to answer what is this, three? And no marks for when you say which artery is this, because this is so easy, right? Still, just write it down. What is 1, what is 2, what is 3, and what is 4. I think you have already started writing. Okay. So 1 is what? 1 is, that's right, it is musculocutaneous. Very right. Musculocutaneous. Excellent. Right? Okay. Then this 2 is what? That if you don't answer this, then that it is shocking. Right? So 2 is Two is muscular. I think you have answered one. Two. Now we are on this two. So two is that's okay. Two. Three. We'll see. Two is this one. Yeah, two is ulnar. That's what I said. That if you don't answer this, it is shocking. Right? And same now it is going posteriorly, and here also it is the ulnar only. That's right. That's right. That's ulnar. 3, as you said, right? It is median. That's right. It is median. And yeah, fourth one, it none other than the brachial artery. Very good. Very good. Now see, to that only we have added something. Now what we have done is everything same, right? All those nerves, arteries, they are same. Just we have extended them, right? So as we said that this is the radial nerve which we are dealing with, and in radial nerve, we said that it will be dividing into at the level. This is the lateral side, right? This is the lateral side. Radial is lateral side, and that's the lateral epicondyle, right? That's the lateral epicondyle. So at the level of lateral epicondyle, this is dividing, right? At this level, it is dividing into two branches, right? One is superficial, second is deep. And this superficial will be traveling all the way. So this is superficial, this one. And deep, that's deep. That's deep. Okay. They are giving all those muscular branches. So here it is deep and the superficial branch, right? Remember, superficial is traveling a longer distance. Right? Let's move further. So here it is, right? With everything. Immediately you have known one thing, that we have added that friend of radial nerve, and that is profunda brachii artery. True? So that's it. Rest of the things you are already known to you. So here is, right, this pair, right? Now comes the interesting part. Say this pair, this royal pair, it comes out via which space, right? Now, in this region, you remember there were three spaces, right? Three spaces. Giving you the hint. Three spaces, right? So, radial nerve and the profunda brachii, they are coming via which space? That's right. That's right. Very good. Yeah, epicondyle means it is the prominence, right? Say when you just take your elbow like this and you try to touch, right? Immediately you will feel that bony prominence, right? You'll feel that bony prominence. On the lateral side, just touch it, right? And you'll feel that bony prominence. That's right. So now, as you have answered it correctly, right? The lower triangular space. So in that case, I would be asking, can you name the boundaries? Can you name the boundaries of this space? Right? You are perfectly right, right? It would be like this, this, and let's draw like this. And this is the space from where it would come out perfectly fine. So what would be the boundaries? So to make things easy, let's mark them this as 1, this as 2, and this as 3. Well, 1, 2, it is so easy, but still 1 is, I would say that is triceps. It is a long head. Yes, long head. Right? Okay. And then 2 is, yes, that's right, is the inferior edge of humerus. Sorry. Inferior edge of humerus. And the 3 is, as you said, right? Very true. It is teres major. Lower border. Perfect. Very nice. Okay. Now let's see this radial nerve officially. All the way, right? All the way till it ends, right? I have tried to draw it in such a way that it becomes easy to remember and easy to digest. So this is what is radial nerve distribution. This portion, the initial portion, right? This much. So that is in axilla. So in axilla, it gives posterior cutaneous nerve of arm, right? Posterior cutaneous nerve of arm. And then, as we said, that it will be giving separate branch to long head and separate branch to medial head, right? A separate branch is given to both of them. Then, as it goes into the radial groove, right? Now it is into the radial groove. So it would give a branch to lateral head of triceps, right? Lateral head of triceps. But it will also give one more branch to medial head. So actually, you see that there will be two muscular branches. One which will be coming from the radial groove and second which will be coming from the axilla. So they both will be supplying to this medial head. So medial head is getting two muscular branches. And then rest of the things, they are all cutaneous. So that is the lateral cutaneous nerve of arm, posterior cutaneous nerve of forearm. They will be all cutaneous. There will be one more muscle, that is the anconeus, right? This muscle will come in the forearm, but do remember that it is this muscle which will be getting its supply from the radial groove. The importance of it is that the level at which the nerve is damaged, right? All the structures which are just below it, they will be affected, right? So that's the reason that even if there is any damage of the nerve over here, right? Over here, yes, lateral head would be affected, but medial head would be spared because medial head got the extra muscular supply from the axilla. So that's why medial head would be spared. Got it? Let's go further. Here it is. Now we are on to the lower lateral side, right? Lower lateral side. So here brachialis, but in case of brachialis, it is carrying proprioceptive fibers. Now what is this proprioceptive fibers? See, proprioceptive fiber is, even if you close your eyes and then you try to move your hand and you try to judge the position of your hand, you'll be able to judge it, right? So this is that sensation of the orientation in, it is in fact 3D orientation of movement and the position of that joint. So brachialis, only the proprioceptive fibers, they are from radial nerve. So this is something which is special. So do remember this, right? Rest of the things, easy. Brachioradialis, don't worry about it. Brachioradialis, now you know from the name itself you can judge that it will be from arm to radial side. And this is all lengthy names, extensor carpi radialis longus, right? But we'll be watching all those muscles in depth. As such, it is so easy. It means extensor carpi. That means it will be dealing with the carpals, right? On the radial side, radialis, radial side, and longus, this is a long muscle. It means there will be another short muscle also. Yes, there will be. And if there is extensor, so there must be flexor also. Otherwise, they would have named it carpi radialis longus. But no, there is extensor group and the flexor group. So there will be something like flexor carpi radialis. No, it will be on the other side, ulnar side. So we'll be calling it flexor carpi ulnaris, right? So that way, there will be several muscles as per their function, right? Okay. So at this point, even if you don't remember this name, no worries. It's a matter of just 1 week. Next week, we'll be discussing it at length. And I just tell you, right, we are getting slightly sidetracked for the next sessions. In next session, we'll be dealing with forearm, right? It would be like forearm part 1. So that would be on next Saturday. Then on Sunday, we'll be dealing with hand 1, hand part 1, right? So what about the other side of the foramen? Well, in the third session, we'll take forearm and hand part 2 together because they all are interconnected. So that's the reason we'll be dividing it like this, right? So forearm 1, hand 1, as it is pretty complex and so many structures. Once that part is understood, and then we'll take the rest of the portion in a single shot. Okay. Let's go further. So now it divides it to superficial and deep branch. Superficial, as we said, that it's a long branch, it will be going all the way, right? This deeper one will be there to supply just few muscles. Here it is. You know this ECR, same full form, extensor carpi radialis, and this is brevis, right? This is a shorter muscle, so it will be supplying this. Supinator, right? Name itself is sufficient, right? This is supination. This is pronation, right? That's the pronation. This is supination. So supinator, we can do this movement. So thanks to that supinator and thanks to radial nerve, especially the deep branch who is supplying this supinator. And the muscles of back of forearm, right? There will be several stripe-like small muscles, right? All of them, they will be part of forearm. So we'll be covering it at that point. But we know that that's the function of deep branch of radial nerve. Let's move on to the superficial branch. One important thing that it will give several cutaneous branches, right? And then all the way, see, no muscles. This superficial branch, because its name is superficial, it is superficial. So its function would be superficial. It is giving cutaneous branches, right? And then it goes all the way up to the hand, right? Up to the hand. And now in hand, it is very typical. In hand, it is the lateral half, right? It is the lateral half of the dorsum of the hand. And in digits, it is 1, 2, right? And then only half digit, right? Only the half, 2.5 digits, except the terminal portion, right? Except the terminal portion. Now see, it is so typical because when the radial nerve would be damaged, right? The loss of sensation on the lateral aspect, on these lateral 2.5 digits, that will become a major thing, right? You'll be able to test that, and you'll know that not only the movement, not only the motor component, but these sensory component, they are also affected. So here we understand it like that this particular nerve, it has got two components. One is the sensory component and second is the motor component. And in sensory component, we are very much interested in, say, this hand, because it has got the classical pattern of lateral 2.5 digits, right? And except terminal portion, except these terminal portion, right? These terminal portion are not biradial, right? When we'll be studying hand at that point, again, all these concepts would come, right? And in tremendous depth, in very good depth, but still good to know because we are now dealing with radial, and that's how the radial plays a major role into this system, right? So that's the profunda brachii artery, right? And that goes into the brachial, the radial groove. Now over here, this profunda brachii is also now going to divide, right? It is going to divide if you see at this junction, right? And this is also known as deep brachial artery. Let's see further. So as it divides, this division is at the level of deltoid tuberosity, correct? Deltoid tuberosity, because we talked about this, that what are the changes which are occurring at the level of deltoid tuberosity. So one of them was like, that's the point where profunda brachii, it divides, right? And as it goes down, this particular artery, right? We need to know this name, right? It is the radial collateral artery, right? That's right, radial collateral artery, right? And that one was, yes, you are right, that is the middle collateral artery, right? Middle collateral artery. Now this radial collateral artery, now see, this is what is called as the anastomosis. What anastomosis is, we must have this anastomosis. Anastomosis means nothing but a diverted route or backup path. So in case if anything happens, that particular organ should not be stranded and should be devoid of the blood, right? So whenever there is one branch which is coming from top, there would be one other branch which will be coming from below against the flow, and it will be meeting, right? So something which is coming against the flow, because as such all the arteries, they are supposed to go down, but then there'll be few arteries, they'll be changing their course and they'll be coming up. When they come up, we call them recurrent, right? So over here, you just watch for this particular artery, right? I'll zoom it. Here it is, this one, right? So it is this junction point where radial collateral, that's this, and this one, it is radial recurrent artery that comes into picture. And that's how they do the anastomosis. Okay. Now, you already said this, right? And this one is middle collateral. That's right. This is middle collateral. Now, this middle collateral, it is descending, right? And this one is the longest terminal branch. It is longest terminal branch. And where it will go, right? It will go into the substance of the muscle which is present over here. Now, fortunately, there is only one muscle which is present over here. There cannot be any other muscle which could be present over here. And that muscle is, right? Because it is when it is said that, okay, this profunda brachii at the level of deltoid tuberosity, right? It gives a branch which is called as middle collateral artery. And this middle collateral artery, right, that goes into the substance of, yeah, that is the, which muscle would be over here? It is medial head of triceps, right? Medial head of triceps, because medial head of triceps, that was just underneath the radial groove. So this is the radial groove. So just underneath that groove, this entire portion is by this medial head of triceps, right? Medial head of triceps. So that's where it passes through. And then there is another artery, right? These are some new names. Just two new names they will be coming up. This particular artery is called as the recurrent interosseous, that is between the bones, interosseous artery. So that's where they meet, right? So that's where they meet. Yeah, medial head triceps, that's right. So this is one more. That's how these arteries, they finally end up. Okay. Now, as we said that, okay, so far so good. But then there is one more artery, as we are watching now in almost the final details, right? Because next time onwards, so we'll be dealing with forearm. So this is like a final goodbye to arm. So we just go for even some short twigs also, small branches also. This one small branch, which is actually coming from profunda brachii, right? It is from profunda brachii, but it is a branch of profunda brachii, and a branch which will be going to deltoid, right? It will be going to deltoid. So this would be an ascending branch, right? Ascending branch. Otherwise, rest of the branches, they were all descending branches. True? Both the one, middle and the radial, they both were descending branches, and then they were going down and they were doing anastomosis. It is only one branch which will go up, and that's the deltoid branch to the deltoid, or the ascending branch of profunda brachii, right? So that's your lateral and the long head. That's completely fine. Okay. Now, by the way, this artery is asking, this one, that who am I? That artery was asking that who am I? Right? This one. Right? It should not feel bad that no one is talking about me. So, which artery is this? Yeah, it's Paka. It's Paka. Very nice. Right? Posterior circumflex humeral artery. Good, good. Very good. Yeah. Now see, this is a very, very interesting thing. As we are talking about this radial now, right? This radial now, the compression of radial nerve, it can be very problematic, especially when the nerve is compressed in axilla. Now this nerve can be compressed in axilla, right? That's the axilla. It can compressed in axilla when someone is using those crutches, right? Because in case if there is any problem in the leg, so then they have to use those crutch, right? Vaisakhi. So that is known. Now when that crutch actually compresses, right, it leads to this radial nerve compression, right? So that's why it's also called as the crutch palsy, because when the nerve is damaged or when the nerve is compressed, it leads to all those muscles which are supplied by radial nerve, right? They'll be paralyzed. So yes, right. What happens to that we'll see, right? But yes, now you know that there'll be loss of sensation on the lateral 2.5 digits, right? All those triceps would be involved, brachioradialis involved, extensor carpi radialis, all those forearm. And this topic will come again when we'll be talking only about hand, because at that point also we'll talk about it. But as it is coming over here, as the compression is at axilla, so axilla is what we are talking about. That's why we are taking it right now. So this is also called as crutch palsy. There is another name of it, right? That name is pretty interesting, right? It is also called as, is there any prognosis when it will be damaged? Prognosis means that whether it will be improved or not, whether the condition will improve or not. Well, condition improves because this compression, and it depends upon that how much damage has occurred. So normally the compression is, as soon as the compression goes away, after some time, right, that nerve automatically comes in. And you'll get this answer, right, just within 1 minute. You'll automatically get it. Now this is so interesting, right? It is also called as the honeymoon palsy, right? It is also called as the honeymoon palsy. Now why the honeymoon palsy? Now it's like when those two persons, they are intimate together, right? So usually it is the female's head which will be lying on the axilla, right? So which will be lying on the axilla. Now at that point, because of the head, that compression can lead to, so because this is like the compression should be prolonged. Say if the person is walking with those crutches, yes, it is not very prolonged, but it's a powerful compression, right? Because those crutches, the entire body weight is coming, right? And over here, say for the entire night, right, they will be intimate, and that head would be causing the constant compression. And in the morning, suddenly it is found that this radial nerve is paralyzed, right? There is a radial nerve palsy, right? And this is classically called as the honeymoon palsy. No doubt this recovers within say 72 hours and everything comes back to normal, but well, it can happen. And well, the Western world, they gave one more name, and they said that it is also called as the Saturday night palsy, right? Well, it depends, right? That's why I say that when on the Saturdays they are free, so maybe Sunday morning when they wake up, right, it's like the hand is paralyzed, right? And surely it is seen more in case of males as compared to females, right? All right. So here it is. When we say that radial nerve, right, radial nerve, it supplies what? It supplies one, triceps, right, that we talked about, triceps. It supplies anconeus, right, right. It supplies brachialis, true. It supplies brachioradialis. Now these are the muscles which are now coming up in, they will be coming up into the forearm. And extensor carpi radialis longus. Now I really want you to focus on this, extensor carpi radialis longus. See, extensor carpals are over here, right? Your wrist bones, they are all carpals, right? And it pulls and it keeps the wrist like this, and on the flexor side it will try to flex the knee. So when this extensor carpi radialis longus is affected, that means there is no one to pull the wrist on the extensor side. So it means wrist will drop on the flexor side. That's what we are watching over here, right? This is classically called as the wrist drop. Wrist drop, right? So that's what is called as wrist drop, and it is because of these muscles, right? Let's see some clinical things, right? Because they are pretty interesting. So, and as you know the course of those arteries, now you know the nerves. So there will be few things which will be pretty interesting. One, that's angiography, right? Angiography, you know it well, right? Angiography is like normally you don't see the vessels, but when we inject a radio opaque dye, the dye through which X-rays cannot pass, right? So they can be visualized, right? You can visualize it. So normally the artery, because on X-ray you can watch only that substance, only those substance who have got the difference in the density, right? Difference in the density. It means here is the bone, right? And on top of bone, if there is something, some soft tissue which is lying, so then there would be difference in the density. But if there are two structures of the same density, so then that thing is not seen properly. Okay, now let's see over here. Here it is this, right, artery, which is seen pretty neat. Now as we see, right, see over here the entire thing, it is ballooned out. It is ballooned out, this one, right? This is what is called as the, and yeah, obviously from the direction you must have figured out that this we are dealing with the axillary artery. So this is axillary artery aneurysm, right? Aneurysm. All you need to remember at this point is that this aneurysm is the bulge, right? It is bulging of the artery, right? It is bulging of artery. And why any of these arteries they should bulge? Because their walls, right? Walls are weakened. Now why they should be weakened? Where there can be several pathologies about it. So that's what we shall discuss in pathology. But right now we just understand one thing, that because the walls are weakened, that's why it is bulging. And it is bulging because it is under high pressure system. Yeah, obviously it has to be under high pressure because it is almost in direct continuation with the aorta, right? So the pressure is high, so it leads to that bulge. When it is bulged, the walls are thinned out, right? Walls, they are thinned out. And when they are thinned out, it means they are liable to rupture. So that is what is called as aneurysmal rupture, and it is fatal, right? Because the amount of blood which comes out, that is so massive and it is so fast that it is impossible to handle it instantly. Okay, let's see something more. So this is the normal site, right? This is the aneurysmal site over here, right? Just to make yourself clear, that's the aneurysm site. Yes. We said that yes, there can be several fractures, right? When the fractures occur, right? This nerve is damaged and that artery is damaged. But see how it can affect patient so badly, so badly. Just forget about this figure. When the artery is damaged, right? When the artery is damaged, artery is carrying that oxygen, right? Oxygen, it is giving that oxygen to that tissue. Now it is not getting that oxygen. It is what is called as the lack of blood, ischemia, ischemia, right? Ischemia. When it happens, then it leads to necrosis. It leads to necrosis, means that tissue starts dying. Once it is died, then a late stage, it's what's called as the fibrosis. Right? Fibrosis. Once the fibrosis occurs, right, it's over. Now over here, watch what has happened. Over here, this is muscular ischemia, right? It is the muscular ischemia. And this condition is why it has occurred. It has occurred because damage to the brachial artery, right? So brachial artery, when it is damaged, it leads to this type of contracture. This contracture is due to this fibrosis. It's those muscles, they get necrosed and then they become fibrosed, and then they are like rock solid structure. So in such cases, movement of hand and is not possible, and because this fibrosis, it occurs randomly, right, in any of the direction. So that's why the hand, its shape, that all becomes, you can see, as compared to the normal one. This condition is called as the Walkman's ischemic contracture, right? C-O-N, contracture. Walkman's ischemic contracture. So this is the reason, that is from ischemia to necrosis to fibrosis. See over here, right, when the brachial artery, as it is passing, and when the brachial artery, any treatment for that? No, so sorry. Once it has to be tackled before the damage is say advancing to this worst level, right? But many times, say if the surgery is done, so then all these ischemia and everything can be avoided. But at times it might be due to irresponsibility of the patient, or sometimes facilities are not available, or sometimes when all these expeditions to say Himalayas and then those poles, right, and something happens at that level. Now this is a fracture, right? This is a fracture which is like a supracondylar fracture, right? That's the condyles. So supracondylar fracture. When this fracture occurs, right, it leads to damage of brachial artery. Now, nothing can be done, right, because this requires immediate attention. Okay, now this is the point where we'll see things in awesome detail. Here is the Orb's point, right? You know the Orb's point or the Orb's palsy. So just from C5, C6 root, as they come out, they lead to formation of the upper trunk, right? And then this upper trunk would be divided into, say, anterior division and the posterior division. And it would be giving two branches, suprascapular and the nerve to subclavius. Yeah, before necrosis sets up, yes, definitely, right? Something can be done. But once the necrosis is set, then it is like patient has to live with it. Okay, so now when the injury is over here, so this is what is called as the Orb's point, right? That is what is called as the Orb's point. So here, this injury will lead to damage to what? Right? It will lead to damage to suprascapular, correct? Suprascapular, because that nerve to suprascapular, right? This is gone, right? Then obviously axillary, true, right? And the musculocutaneous nerve, cutaneous nerve? Because it is the upper trunk, right? Upper trunk's anterior division is taking part into that lateral cord, right? And then from there, this musculocutaneous nerve was going, right? And also its posterior division is taking part in the formation of posterior cord, and from posterior cord the axillary was going. So when it is damaged, right, what really happens? So let's see all the structures step by step. The first, from the top, will go all the way, right? So let's mark them first. We'll see this. So that is first, this is the, so let's write it like this: muscles, right? Muscle affected. Can you see it? Okay, it's below. So muscle affected, and then what's the final position or the abnormality? What's the abnormality, right? What's the position of the hand, right? Or we can say what's the final position. So that way we'll be able to understand both the things. So first muscle is like deltoid, right? The deltoid is affected. Now you know that deltoid, its function is abduction, correct? It contracts, right? It contracts and its function is abduction. Now this muscle is not working, so then its counter big muscle, pectoralis major, is there. So this pectoralis major will contract, right? So it will lead to adduction. Got it? So because deltoid is not working, that's why the final position is adduction. Got it? We'll create this entire image, right? We'll create, and you can parallelly keep on creating it on your hand, so you never forget. So first, because I'll write it over here, adduction because of packed major. Okay, good. Now let's move on to the second spot. Let's take another color, and over here, supraspinatus and infraspinatus, right? Supraspinatus and infraspinatus. What were they doing? Supraspinatus and infraspinatus, they are on the back side, correct? So when they contract, right, they will take the hand, they'll take this arm externally rotated, right? Because see, supraspinatus, infraspinatus, they are on the back side. When they are not there, so there would be internal rotation, right? Because internal rotation, that will come into picture as external rotators are affected. So supraspinatus and infraspinatus, they are affected. So that is what will lead to internal rotation, right? And supraspinatus, infraspinatus, because of the suprascapular nerve is damaged, right? So obviously, right, it will go like this. Okay, now the third point, let's mark this third group. So it is over, you can mark it over here. Biceps, right? Biceps brachii. So function of biceps is the flexion, right? Now biceps is not working, so obviously the hand would be extended, right? It was the biceps which was keeping like this, right, into the bent position, and now the triceps would take over, right? Biceps not functioning, so final position would be extension. So it would be extended. Try to do this thing and immediately you will know that, okay, adduction, right, internal rotation, and the from elbow extended, right? Right now we have not talked about the hand, right? We have not talked about the hand, but at least the muscles which we have learned, this much position is easily understandable, right? Don't worry, we are taking rest of the two steps also, and they will be repeated when we'll be learning the hand. Okay, so here is the fourth muscle involvement. This fourth muscle, right, it is supinator, right? We talked about it just a few minutes back. Supinator, right? Supinator, right? So it is the supinator. Now this supinator is not working, so there would be the pronator. Pronator teres, pronator quadratus, there are two pronators. So they will take over and they will make the hand like this. So add this. So hand would be into the pronation state, right? It would be in the pronation or the pronated state. Add this thing. So adduct, internally rotate, extend from the elbow, and now, right? Say if this much is extended, now you have got two options, either supination or pronation. Now you pronate it. So when you pronate it and it goes like this, right? The entire hand, right? Now your wrist would be going back, right? It is pronated. And the fifth and the final portion, right? That is over here. We saw that it supplies extensor carpi radialis longus. The function of extensor carpi radialis longus is the extension, right? And there are flexor group which are flexing. But this extensor has gone, so now it would be flexed, right? So this is how the hand would look like, right? So it is, so I just write it down, right? That over here, it would be the, extensor of wrist and fingers. Can you see it, or it is coming behind? Just a minute. Wrist and fingers right? And that is due to, so the final effect would be the flexed wrist. Correct? These are the 5 states. This is what is collectively called as the waiter's or the porter's tip hand. Now everyone would be telling you up to this point. I would like to add one thing to this. Now when we say C5, C6, right, they are affected. Now you know that from the C5, C6 and even from C4, that is when from C4 and C5, when that is also involved, right? When this is also involved, it leads to, there is a nerve called phrenic nerve, right? Just now let me write it like this, phrenic nerve. This phrenic nerve will be giving supply to diaphragm, which is between the thorax and the abdomen. So when the diaphragm is affected, right? So over here, so in case if C4, C5 involvement is there, and in which case the phrenic nerve is damaged or the phrenic nerve is affected, so this would be like a diaphragm is paralyzed. So in such case, diaphragm would be elevated. So that is what is called as the diaphragm elevation, right? Diaphragm elevation, and it can really be seen, right? So just an important point, do keep in mind, right? Because such points, sometimes they give you tremendous credit, right? So that is how this system, it works, okay? And if you try to do this position, that is adduction, right? Step by step, adduction, then internal rotation, extend from the elbow, and then pronate your hand and the flex your wrist, immediately you will come across precisely all the positions properly, right? Okay, this is classically when the radial nerve is damaged, right? Radial nerve damaged. Because this is fracture of shaft of humerus, right? And it's an extensive fracture, so definitely there will be involvement of the nerve, right? This is how it looks like, right? Okay, now something very interesting. If you really want to test, so to test, we have got 3 major nerves to test, right? We want to test ulnar nerve, we want to test median nerve, and obviously we would like to test radial nerve. So let's start with first one, ulnar. Right. So to remember it, we can write like, just for this purpose, just for this purpose, ulnar nerve. Right. Say every time, right, you'll find in medical they are very fond of giving names. So this is what is called as the peace sign. Right. So some questions like that peace sign. If patient can do this peace sign successfully, it means his ulnar nerve is working properly. His ulnar nerve is okay, right? So peace sign, this is called as peace sign, and peace sign is for ulnar nerve. So we don't forget it. That's why we wrote it like ulnar nerve, right? So that you don't forget, right? It gives the visual impression. So this is first thing. Okay, so ulnar done. Let's move further. Over here, the second one, this is called as the hitchhiker's sign. Hitchhiker sign. So in other words, a thumbs up sign, right? Thumbs up sign. So when, or say thumbs up sign. This sign is for radial now. Is for radial now. How will you just remember it? Because from here, right, you'll find that it is this nerve which we are testing, radial nerve, right? So when that is up, so when this thumb would say, yes, radial is fine, right? So because radial, this side is radial, right? This side is radial. So that's what this is telling, that yes, radial is good, right? Radial is okay. Radial is fine. Hitchhiker's sign. The next one. And this is for peace. It is called as power to people sign. Power to the people sign. And this is for median now. I used to remember it like that when you say median, right, it comes like some union, right? Median, union, right? Pronunciation wise, they both are very similar. So whenever there is any strike or anything like that, narebaji, etc., right? They just keep on doing like that. So that's how I remembered that it is this union, right, that gives this sign, and it is the median nerve. Now in this median nerve, right, there is a branch of it, right, which will come in forearm, and that branch is anterior interosseous nerve. So once you have done this, right, so this is like all fine. But if you really want to test that anterior interosseous nerve, so this is what is called as the OK sign. This is called as the OK sign. Right? It is for median nerve, but to be very specific, when you are testing anterior interosseous nerve, right? So this is for whole median nerve, and that's for anterior interosseous nerve. I included this part just to give you the idea that what exactly we shall be learning in hand. Why it happens that, say, doing hand like this, it checks the median nerve. Yes, it has to be, because when it does like this, right, at that junction we'll be talking about that it is the median nerve which will be say supplying all the flexor components, this, that, it's okay. But when we say median nerve, if you can do this, it means those flexor components, they are working fine, right? When we say this thing, it means that it is this which is called as the opponents, right? It means this thumb is working fine and this index finger is working fine because they are specifically supplied by the anterior interosseous nerve, right? When we say that, okay, this is okay, it means it is the muscles which are over here, right? This will also be called as the anatomical snuff box, right? It will come in more detail, but that portion is working fine because it will be supplied by a radial nerve. And then when we say this, right, it means the ulnar, which is going good, right? And if you just remember this, it will help you a lot when we'll be discussing the hand, that is the forearm and the hand, right? So that's it for today, right? And thank you so much. We meet next week, right, with the forearm part 1, right? And then immediately after that, it would be hand part 1. And then we shall take forearm and hand part 2 together, right? Thank you so much. Take care and happy Sunday. See you. Bye-bye. Yeah, obviously we are regular, right? Because it is planned for every Saturday and Sundays. Yeah, we are planning for more lectures on other subjects, right? You will be updated about it. Okay. Thank you so much.